see, I have noon. Are we all ready to go? Everybody good to go? All right. I have noon. I will call this meeting of the Budget Committee to order. Give a roll call, please.
Allers. Deacon.
Here.
Hensley.
Present.
Lester. Here. Healy.
Here.
Schwartz.
Here.
Spencer.
Here.
Spicer. Wiseman. Wright.
Here.
We have a quorum.
Very much. First item on, I understand, is presentation and discussion regarding health insurance. Is that right?
Yes.
All right, Chief.
Yep.
Barry.
I will kick off. Thank you, Mr. Chairman. Thank you, Council. We just wanted to kind of circle back again to some ongoing conversation that we know that the Council has had and the staff certainly has been having for the last few weeks. And we wanted to produce some information publicly to the Council and the committee on the journey we have taken. And what we did was we knew that by bringing forth the concern again for supplemental and part of our health insurance currently, we knew that was going to be a challenge for the city moving forward. And so we decided that at that time it was important for us to take a moment and have a tactical pause and say, we need to really pursue our options, look more deeply into what is out there, what is possible, and whether or not a change could be considered not only in the future but in the near term for FY24 as part of this budget process. So we started that conversation a little bit at our last budget meeting. We wanted to hopefully bring forth some more information to you today. So I'm going to kick it off. I'll hand it to the Director of HR, and then I believe we also have some special guests, our consultants here from Wall Street. They're also going to present some information, but most importantly, we're here to answer your questions. So to do that, I'll just say this. We were originally optimistic that a fully funded option might be something we could consider. And that was primarily based on one fact, that we felt like with a very large pool that we could join into, that we might be able to share and diversify our risk and be able to be more competitive with the cost. We were optimistic about that. We pursued that vehemently. And at the end of the day, our analysis is that pool is much, much smaller than what we originally thought it could be or would be. So I think that our specific options, we kind of tried to categorize in 4 different paths forward with some various additional decision points in the future. But I will let the Director of Human Resources kind of lay those out for you in a very concise way, if that's acceptable to the committee. Please.
Okay, so one of the first areas that we looked is with an organization called Midwest Public Risk. They are a public entity out of the Kansas City area. They are a group that we are familiar with. We do have our liability auto insurance with them. They do have a health insurance pool. So their pool is about 5,300 members, lives covered on the health insurance. Probably the biggest concern that we've always had with Midwest Public Risk is just their policy year. Their policy year runs on the July 1 to June 30 calendar. I think, as everyone knows, our calendar for our benefits is January 1 to December 31st. So switching that would be incredibly painful for the employees. It means if we were to switch to them starting this January, the employees would be picking an insurance plan for 18 months. And their deductibles would reset on July 1. Now, there would be a little bit of grace given on the deductibles on the PPO plans the first year, but they would still have the deductibles start over again. That's very difficult. All of that could be overcome if we thought that it really was the right place to go. So that's why we went to them. I will say, though, we did receive a verbal declination from them yesterday, which basically means they are declining to give us a quote.
That was NPR.
Yes. The second organization we looked at is what Chief alluded to as Missouri Consolidated Healthcare Plan. That is the public entity plan for the state of Missouri. So Missouri Consolidated handles all of the state of Missouri employees with a health insurance pool. They also have a separate public entity pool that matches the state plan, but it is a separate pool. So we took a look at that. We did get some rates from them. The rates, which is where we were initially very encouraged by, were favorable. They're very similar to what we're charging. But their pool has 1,237 members or lives. That's how many people are covered in total within their pool. So if we were to switch to them, we would be close to doubling the size of their pool. What we really look for in a pool is something that's large enough that it is spreading all of the risk. And if we are by far the largest group in the pool, that means we're actually probably assuming more risk than we're sharing. So the staff feels as though that is not a safe option. And there's some other things with it as far as, we'd still have runoff costs in January, for the first part of the calendar year. We would lose all control of trying to contain medical costs. There's other things that go along with it to where our staff does not feel that's a viable option. The third one is we have asked our broker, Wall Street, to look for other fully insured options, and they are working on that. The requests that they put out, and I think they can address this more. The insurance companies are requiring claims through the end of August, which would not be obtained until around September 12th. And then they would have to have, time to get it out. So probably looking at around the week of September 25th before we would get those kind of options. So that is still out there. And then the fourth is to stay, kind of with our current plan, working with our broker, working on cost containment measures and things with Anthem. And they can talk some more about those things too. So that's kind of where we are right now. So I think if it's okay with all of you, I'd like to kind of turn it over to Randy Lucanati and Cassie Limley with Wall Street. So
before we do that, does anyone have any questions for Ms. Stroh?
Follow up on what I previous, but I could do that.
And Mr. Smith, would you mind temporarily? Oh, absolutely, yeah, we can do that.
Move them up if we can.
He wants to wait up.
Sheila, they could sit over here too if you
it's
want.
perfectly fine.
Okay.
Did you have questions first?
Welcome.
Welcome.
Thank you very much for being here and sharing that information with us today. Yeah, are there any questions for Ms. Lemley and before they? Please proceed.
Okay.
Thank you very much, Council, Mayor, and the Gale HR team for the invitation. Just maybe a little bit of quick history of why we left fully insured way back when. So I'll dive into this with being respectful of your time. So I'll talk a little about fully insured versus partial self-funding, which is where we are today, give you some history, and have Cassie address some of the where we are today, why we made the change from United Healthcare 1/1 of 22, or 1/1 of 23, excuse me, to Anthem, and we've got some results there that's showing that was a good thing from a clinical and cost perspective. Some of you.
Sorry, during your presentation, if you could give just like, not even 30, like a 60,000 foot view about perhaps the differences functionally and cost-wise, everything between the self-insured route we've been on and perhaps more conventional coverage.
Sure.
That'd be great.
So, and I appreciate that. When Missouri Consolidated was formed and the state of Missouri created that, there was 5 companies at the time that came in, and back in the day of HMOs, very aggressively came in and bid on that business for the state to pick up the state employees. Then they opened it up to municipalities to join that. So we had a lot of municipalities that we worked with as their broker advisor that went into MCHCP across the state. That grew very quickly. It was the best premium you could get and the best benefits back in the days of HMO. Really, you stay in that network is very low cost to the member. That was short-lived because as the claims overcame the premium, the rates for those benefits and those plans really went through the roof, and the enrollment of all the different municipalities dropped out of MCHCP. As Gail mentioned, they have over 200 employers in it today. And if you divide that by the number of lives, that's about 4 people per employer that are in that. A lot of sewer and water districts in the rural areas, which is a great opportunity for them. But almost every large employer left that and went into either fully insured or self-funded. And so a little history about why you were in MCHCP, why you left. The rates were not competitive anymore. We work with a lot of employers across the state of Missouri and beyond. Most employers that are 100 lives or more, and that's usually the tipping point, generally look at partial self-funding and move away from fully insured because of what's become this rising continual cost of the fully insured plans. Especially when you go over 300 lives, most every employer in the state of Missouri that's 300 lives or more has moved into partial self-funding. It's a way to break all the claims apart. It allows us to do more clinical management, and frankly takes the profits away from the carriers, be it Anthem, United, Aetna. When you're fully insured, they're taking the risk, they're taking the reward, plus you're generally getting a renewal each year based on your claims. And if you're fully insured and you have a tough claims year, and we've had some high claims with the city, there's no saving grace in fully insured. You're gonna get a continual rate increase, and we've seen rate increases, significant rate increases on employers under 100 who aren't large enough to even look at self-funding. That doesn't take the pain away of continually rising cost when you have an ongoing claims pool that continues to have some ongoing claims as the city has had. And with that, we try to work with you all as your risk management advisor to look at the medical and the pharmacy and continually work to get you all the best pricing when someone goes in and needs access to care. So what are we paying for it? Not what the member's paying beyond their deductible and coinsurance, but what are we paying? And I do want to mention one more point and take a question or any questions you might have. When we say self-funding, it is partial self-funding. You're not totally self-funded with no reinsurance. So we have reinsurance at the specific individual member level of $125,000. Claims under $125,000, the city pays first. Obviously, the member pays their deductible and their coinsurance. The city pays up to $125,000, and then your reinsurance carrier steps in for that other large claim. Then you also have aggregate coverage, which is a ceiling umbrella, where if you have a lot of individuals have claims that are up to that 125, there's a point that you would hit to where the aggregate would step in. You would no longer pay an individual claimant, and you would hit that ceiling, which is not what you, of course, want to do. We want to have claims below that. So you are protected with reinsurance, and we continually shop that reinsurance every single year. And we are doing that at this point. We're also looking at fully insured carriers, and we will do that, as Gail mentioned, from the time standpoint. But with the claims that have been ongoing the past few years, I would suggest that fully insured probably is not going to come back competitive. If they do, we can look at it, but you will have to pay claims run out, which Gail mentioned, because if we leave the self-funding, partial self-funding January 1 of 24, there's still claims that have been incurred. If I had a knee surgery, November 22nd, and that claim doesn't get submitted and paid until February, March, the city still has to pay those claims. So we're gonna have a run out period where you're gonna have cost of your plan for several months, plus a new cost of fully insured, almost double the cost for a few months. And the goal of that would be the fully insured is so competitive that it's attractive to do that. And we'll see if we get competitive quotes back, but we've already had some declines, just like from NPR, based on the claim. So I threw a lot at you trying to keep it the 30,000-foot view. Let me stop with that.
What is the reinsurance amount for the overall?
So you all have, it's $125,000 at the individual level, and then each year they're looking at the claims of the group and giving that aggregate level. I don't have that right in front of me, but it's around
$3.5 to $4 million during the current year.
Okay, thank you. Great question, thank you.
So we have a $125,000 per covered
life.
And you may or may not be able to answer this, and I'm going to be sort of as undetailed as I can be, but my understanding is where we've gotten in trouble in the last couple of years, and the reason we're having this conversation right now is because it's not even necessarily because of next fiscal year, because even though it will relate to next fiscal year, but it's because we are anticipating another hefty supplemental appropriation to finish out the current fiscal year of over $1 million, maybe $1.5 million. And my understanding anyway was that was related to a particular claim. So how do we get to a $1.5 million supplemental if we have a $125,000 limit for each cover line?
You do accept, the carriers can laser an individual. You all currently have a member, mention names obviously, that is lasered. A reinsurance carrier, when they give a renewal, just like when we go through marketing this year, we're asking for proposals at the $125,000 level. We're also looking at a couple higher levels, which may make sense for you all, premium-wise, because it's fixed dollars you're paying. Those carriers have the right, what's happened the last 10, 15 years in the market, they will laser out an individual high claimant. If they know it's an ongoing high claimant, they're either going to raise your rates through the roof on the reinsurance premium, or what they call laser, which is moving that one individual or individuals to a higher specific deductible. So you all have one claimant that's been ongoing for a while that is lasered at a higher amount than the 125.
First time we've talked about lasers in a budget committee.
That's a $900,000 laser currently.
But while I've interrupted and stopped things, any other questions at this point before they continue?
What is the aggregate coverage though?
The aggregate ceiling is made up every year of your demographics, and it's around that $4 million range plus your fixed cost and so forth.
Yeah, and that's everything that rolls up under that umbrella. So if there was a catastrophic event, lately we've been using the global pandemic as the example, or a tornado, which we've all been through here recently the last few years. If all those things were happening going toward that ceiling, and the city were to reach that ceiling, the stop loss carrier would then step in and pay above and beyond that.
And I guess for layman folks like myself, I would deem a catastrophic event being that in one individual paying over $1 million in claims in
And
one year.
that does go toward your ceiling.
That does go towards
Yeah,
the ceiling,
it does.
but our ceiling is not low enough necessarily to really have that impact.
Well, so you're running at about 85% of your ceiling at this point in the year with claims through the end of July. We track this on a monthly basis using what's called an aggregate report. And so through July, we look at the stop loss carrier gives us an amount that kind of tracks to each person that then sort of accumulates to that ceiling month over month over month. And so through July, your ceiling is here and your claims are here, and you're about 85% of that ceiling. So it's not that the stop loss carrier didn't rate that appropriately, because right now you're running pretty close to it, which then again goes into the renewal. They take that into heavily factor that in when it comes to creating your renewal as well. Does that make sense?
Unfortunately, yes.
Yes.
Councilman,
So when you said the laser currently is 900,000, so that means now we're responsible for that individual 900,000.
Correct.
Yes. Yes.
And going forward, I guess, can they raise that more, or what's the expectation?
They can. We have a great relationship with your current stop loss carrier as Wall Street Group. We have a very good block of business with them. We have a great relationship with them, and they have told me verbally that they won't raise that for us. Now, that doesn't mean that they won't do it if their underwriting pushes back on them. In the last couple of years, we've also put in a couple of provisions on your stop loss policy. One of those is a no new laser policy. So right now we have the one laser at 900,000. They can no longer put a new laser on the policy because of that provision. In addition to that, we have a 50% rate cap, and you might think, oh my gosh, 50%, that's a lot. It is, but if you think about not including any no new lasers, they're going to have to make up for that somewhere. So capping it at 50% is also in there as well.
So there's a real risk of switching reinsurance carriers.
Yeah,
Like we've done in the past with switching to different primary carriers.
yes, there is.
Great question, but we do know those parameters when we look at the carriers, and before we would make a recommendation to move, even if we look at going from 125 to 150 or 200, does that make sense financially? And we'll lay all that out for your all's consideration. And there's other carriers that will do no new laser contracts. That doesn't mean the current laser, they're probably going to bring them over at the current amount, but having no new lasers built in the contract obviously is a safeguard. Not all carriers will do that.
That's right.
At what level on that particular claim that's at 900,000 that's lasered out, at what level of claims was it triggered to be lasered out?
In today's world, for you all, you're at 125,000. So when an underwriter is looking at the ongoing claims of high claimants, so this year as we shop this out, going forward, they're looking at all the claims within the group, employees, dependents, and so forth. Any claimant that they look at the case management notes, the diagnosis, and they expect future cost, they're looking at where they believe that will come in at. If it's someone they think it's 100,000, of course it's not a risk to the reinsurance carrier because you're paying up to the 125. If we have someone who they know is going to be, 50,000 a month on a high costing specialty medication, 600,000 a year, they know if that member stays insured, employee or dependent, that's where they're going to come back. And currently there's no new laser allowed, so they may raise it up all the way to 50% on the renewal. But if you don't have a no new laser, they could come in and add a laser to that person. So hopefully that answers your question. But every week we can't predict knowingly every year going forward because it's all going to come down to your ongoing high claimants, what's going on with their case management, what's the diagnosis, what's the prognosis of that.
Is this relating to a claim within the last, or this year from January 1 till now, or is this a multi-year claim?
It's ongoing. Yeah, it's been ongoing since the member joined the plan.
That's the Lester. Thank you.
Do we have others or many others that are beyond that 125 limit?
As far as high claimants?
Yeah, two more right now. There are 3 with ongoing high claims on the plan right now.
Councilman Schwartz.
How, in your experience working with multiple different entities, whether they're governmental or private or whatever, when self-insurance became kind of a thing, how have it, not every person that gets into a self-insurance plan has a taxing base like we do that we can tap into. So how, in your experience, what have people done when they've been at individual A lasered out and they've had a catastrophic amount of money they had to pay? What are your options at that point?
It is limited because if you have ongoing risk, going to a fully insured carrier, as we'll work through and see if we get proposals or declines, they're looking at the same claims information. So it's how much premium on a fully insured basis you're going to have to pay enough premium for them to feel like they're covering that risk, plus a fully insured carrier's profit margin, which we've cut that out going self-funded. But great question. I mean, we have employers out there today that you have the ebb and flow of what claims are going on within your group, again, employees and dependents, and over the past several years, with the high costing specialty medications that you see advertised every night between the sports and weather and so forth, it's great from a humanitarian perspective that these covered members and their families have that type of care available. That may help them with the condition they're dealing with, but they are very expensive. And now we're dealing with that, whether again, you're fully insured and you have that type of a claim, you're going to get a huge increase at renewal, or partial self-funded, you're going to see it in your reinsurance and or a laser if you have a program that allows you to laser it. So there's many employers most employers, one of the biggest frustrations they have, any type of industry, is this is the one benefit that's extremely important for attraction and retention, but it's one of the few things that you really have very, very little control over a budget standpoint because it's subject to claims that your members are having. And most of us, when we go in for care, if it's us or our loved one, I mean, we want the best care we can get. You typically don't know what it's going to cost until you have the service provided. So it's one of the few things we purchase as consumers where you have no idea what it's really costing you, before you go in and have that care. And we're not talking about a doctor's visit or a small prescription, but be it a car accident or whatever it may be, a heart transplant, ongoing high costing medication, these can be very, very large claims. And so it is extremely difficult to budget that. If you find yourself in a position where you have ongoing claims, it's going to continue to be a frustration for any business to budget that. So hopefully I helped answer your question, but there is no, silver ring you can.
This may be a good idea to also talk about why we moved from United Healthcare to Anthem last year. And this is something that we look at on a really biannually, sometimes quarterly basis, is just to see how the plan is performing. About a year and a half ago, we looked at the United Healthcare performance, and I noticed that the discounts, meaning you go in for a surgery, and Anthem, United Healthcare, whoever the carrier is, has a contracted discount for that service. UHCs were running right about that time at just over 40%. That's very low for Central Missouri. And so we did a deep dive into the Anthem network last year, ultimately recommended the city move to Anthem as their third-party administrator using the Anthem network, nationwide network for your employees. And that has proven to be a positive move simply from the network discount. So for example, I said 40% a bit ago. The 2022 plan year averaged about a 44% discount on the network on the United Healthcare side. We're already at 62% in 2023 under the Anthem network. So we are constantly evaluating ways to save the plan money when the member goes in for service. So there's only so many ways that you can really control that. The network discount is a major way, and we do have an eye on that.
So I don't want to get too deep in the weeds here, but to keep it at the 30 to 60,000 foot level, can you compare our situation we're currently in versus if this individual was in the ACA portal versus like a traditional Medicaid claimant? How are those treated different than what we are doing now?
So if I'm understanding your question, if a high costing individual was in the, if they were purchasing coverage individually under the ACA, there is no more pre-existing conditions in the United States when the healthcare reform law was passed. And just to step back from that for a moment, years ago when Randy was a new employee, obviously you don't ask those questions, but there used to be a 12-month period of not covering pre-existing conditions. So if I had previous coverage, you gave credit for that. But if I didn't, and I had a knee issue, I wouldn't come to the city, get on your plan, then go have a knee surgery. It wouldn't have been covered before ACA. With ACA, there are no more pre-existing condition limitations in the United States. So immediately when you hire someone, themselves, their dependents, they're covered from day one. So that's changed. That's definitely driven cost. If they do not have coverage available through an employer, their options are going out to the individual market through ACA, the Affordable Care Act. Those coverages are not very rich coverages. The premiums are expensive because you generally have people going there that aren't having other options to purchase coverage, but they could go there, purchase coverage, and pay X amount in deductibles out of pocket, and then that claim would be covered. There wouldn't be a laser type situation because they're not in a self-funded plan. They're just in an individual plan through Blue Cross United or whoever. On Medicaid, of course, they're coming under the federal program, and there's very little cost to someone who qualifies financially for Medicaid. But again, that would be an individual that's looking to do that, or I could possibly be an employee here, and maybe my children qualify due to household income, if you will. And then, of course, Medicare, for those who are generally 65 or older. It's being pushed up now for younger people retiring. Your employee, if I'm 67 and still working for the city, I still have full access and rights to be on this medical plan, just like any other employee. If my spouse is 67 or at least 65 or older, in a lot of situations, if they're not working, they would be better off to go on a Medicare supplement and go on Medicare and purchase a Medicare supplement versus me covering them as a dependent under the employer's plan because of the cost of that versus what Medicare supplements would cost. So I hope that answered.
No, it does. Excellent. Thank you.
Right. And just to be clear, the elevation limit I set on my initial question does not apply to the rest of you. Any members are welcome to dive as
You're the chairman.
To dive as deep as you want. Councilman Lester.
You may know this, and maybe Drew may know it. So what's the percentage of the total employee compensation that healthcare is?
We wouldn't know that, but
Healthcare what percentage of our total employee compensation?
As a whole, I don't have those figures in front of me. I will say that our health insurance, if we're talking for individuals, it all depends on the individual, whether they're covered under employee only or a family plan, because we do pay more for the family plan than we do for an employee only plan.
I'm just talking on average across all the employees.
So citywide, I don't know, that's something that we'd have to pull that information if we could.
Put that together. Right.
And just to remind the room, we are about halfway through our scheduled time for this afternoon. Councilman Spencer.
So one of the advantages of the self-insured plan, from what I understand, is that you control the data. And that would, I think, would normally dovetail into a wellness program. But our wellness program is really lacking and deficient, I think. I think some of previous brokers, employees have stated so, that suggestions have been made but have been ignored. So I feel that we're not capturing a lot of data that could tailor a more efficient and effective health and wellness program, whether that is to address issues like diabetes or tobacco use or anything like that. So how can we improve that to where it would help offset costs? Because that's the whole point of a wellness program, is to really impact your bottom line for cost.
So I would say two things. I might have Cassie speak to the clinical side. Under wellness, there are strict guidelines of what you can or cannot do from a premium differential. There's certain things you can do under a wellness program. Ultimately, encouraging those members to get their annual well man exam. A lot of times a premium differential. So you all have there's certain things you can do within that. Then you move into a clinical state where someone maybe is a diabetic, to use that example, and there's different clinical programs that can be offered to those members through the pharmacy or the medical plan. If you want to expand on that at all.
Yeah. Anthem does have some of those types of programs, but again, to Randy's point, there are only so many things that you can do to base your plan participation or rewards or incentives off of actual health outcomes, because it has to be fair across the whole membership. You can't really point people out and say, you have diabetes, you have to do this program, or you have diabetes, so you get a lower benefit, that sort of thing. Gail and I and the team have been working on a wellness RFP just to really determine the best vendor to enhance the wellness program going forward. And I think we're close to that. That may have been shared previously, but we are close to having likely a change in wellness vendors to hopefully help enhance that, where there could be some data sharing from Anthem into the new wellness vendor to help with some of that, to help contain those costs.
Councilman Mealy.
I don't really know who to ask, but do we currently offer, like, for lack of a better word, a discount for, like, if you don't smoke and you sign that you don't, or do we have those things?
Well, yes and no. So we do have a wellness program, so employees can participate in that program, and they do get an incentive, a premium incentive off their health insurance by earning a certain number of points. And if, if they are non-smokers, they get a pretty large amount of points.
Okay, so is everything on that point system then? Mm-hmm. Okay, thanks.
You mentioned about the costs of prescription drugs, which is huge. And I know a year ago, I don't know how long ago, we're doing brokers, and I know prescription drugs was the main part of that. And more recently, I think we tried to do things. I don't know if the switch to Anthem was part of that, but if you could comment some on recently whether we've made any headway in terms of containing some of those costs.
Yeah, Anthem has a specialty drug program that specifically targets cost and where you're obtaining those specialty drugs. Specialty drugs are like the injectables, those high cost ones that you see on the TV commercials in the evenings. There is also, we work with another consultant called Leaf Health. It's a third-party consultant. They are not in no way connected to Anthem or to us, other than we hire them to work with our self-funded clients. They receive a data feed every month from Anthem that we're making sure that they are armed to review the pharmacy plan to make sure that Anthem is upholding their performance guarantees from a cost, a rebate, a dispensing fee standpoint, and they're really holding them accountable for those. Just as an example, we have some reviews going on right now where they are holding PBMs accountable, and PBMs, pharmacy benefit managers, sorry, gotta get, I have to remember that I'm the only one that knows that lingo. The pharmacy benefit managers to write a check back to the clients for underperformance on those guarantees. So that's just an example of some of those cost containments on the pharmacy side. Anthem also has a new, what they're calling white glove specialty program that they're coming out with in 2024 that the city will be able to take advantage of, again, for just making sure that your employees, your members are receiving the right type of care at the right place of service, and that we are obtaining that drug in the most cost-effective way. Lowest net cost is what the kind of the lingo that's used.
So, and you know, measures of before you've done these things and how it's impacted to show that there's been some benefit in terms of cost containment?
Yeah, can I give you a real life example? Do we have time for that? I will make it quick. There's another municipality that we work with here in central Missouri. They had a member on their plan that was taking an infusion drug. This drug cost $200,000 per infusion, and it was a series of 8 infusions. Y'all can do the math on that. This was happening toward the end of 2022. So we're in the renewal cycle season, and the stop loss carrier goes, hold up, this is a really big expense, and we're going to put an $800,000 laser on this person, okay? And as you all know, those large lasers are pretty detrimental to your plan. We were able to step in with Leaf Health, our consultant, and completely change the site of infusion for that member, as well as procure the drug from a different vendor. Basically, it's called white bagging it, meaning that the drug was shipped directly from the manufacturer to the patient's home, and it cuts out the middleman and cuts out a lot of costs. We completely eliminated that $800,000 laser on that patient. And that person then just ended up falling under the normal specific deductible for that plan. So that's just an example, a real life example of how those programs are really helping employers face those large medications.
You might mention on the high claimant we have here, we have on the same thing.
Yes.
That medication, there's not another path, but we are continually working on that to see if there's a lower costing alternative without obviously negatively affecting the member. On their health care.
I had one more question, but he had his hands up.
Just quickly along that same line with that same example, I mean, did that shift any cost to the member?
No. It actually decreased the cost for the member.
Decreased? Thank you.
So Spencer, and then we're gonna get back to your prepared remarks.
Yeah, so based on a recommendation from our HR director, I've kind of used the analogy. The recommendation is to find a broker that has more horsepower, so to speak. Could you, since you have the attention of most of the council, could you address maybe why we shouldn't take that into consideration?
Sure. Two things. One, Wall Street Group, obviously we're a local agency, started 30 years ago, myself and 3 other gentlemen, and were privately held until 2017. We became part of Acrisure. And I'm proud of our history before that, but becoming part of Acrisure, it's may not be a household name, but if you're a football fan, Pittsburgh Steelers fan, what was Heinz Stadium is now Acrisure Stadium. It's a name you're going to hear more and more. The reason I mentioned that, Acrisure is the 6th largest risk management financial company in the nation. So that is who we are. We are Acrisure. We still market Wall Street Group Acrisure. So, I would stand proud against other competitors, and you've got other competitors out there from Lockton to Gallagher, USI, go down the list, Brown & Brown, Hub. We have, in my opinion, all the resources, and in some cases, I think stand up more when you get into HR compliance than any other national provider. So I guess the main point there is we're not a small local firm, very proud to be here in Jefferson City, obviously. We are part of an extremely large national broker. The issue with claims, I think we've kind of hit on that. We're continuing to work just like moving from United to Anthem. We know this market. We live here. Our employees live here. Our children school here and so forth. We know Central Missouri and Missouri, work throughout Missouri, but we know, just like with Anthem, where the best discounts are. So we've made that transition 1/1/23. We are working on the pharmacy to do everything we can to control costs there. With all that said, you could interview 5 brokers today. They're all going to tell you they do a great job. We have really good competition. They all do. So rising cost of claims, no one can totally predict. So when those claims happen, it's getting the best discounts when they go to a medical provider, getting the lowest cost when they purchase prescriptions, and not to leave a negative note from a financial standpoint, but it is, every employer is dealing with this frustration. To your question, Mr. Councilman, generally your employee benefit, your medical is the second largest expense you have behind salaries, if you will. And every employer is dealing with this rising cost. We're going to continue in the United States to see ongoing high-cost claimants because of these high-costing, especially medications. Cassie gave you an example. We have another client that had, just as a point of reference, it's called bulging eye disease. 8 treatments, $1.5 million at the University of Missouri. We worked to get that down. That's wonderful for that person that had to deal with that condition, but $1.5 million for any employer, whether you're fully insured and that carrier comes back and hits you with a huge increase, you have to absorb and pay for those costs. And we have no end in sight. I'll pick on Big Pharma. Big Pharma is coming out with all these new biotech medications. That's wonderful, but they have patents on those drugs when they come out with them, and these are extremely expensive medications that are being advertised to all of us direct to consumer every time we turn on the TV. And and members are going into the doctor saying, I want to get the purple pill. I want this. I want that. I want the latest form of rheumatoid arthritis treatment versus a $300 pill. I want to take a $5,000 a month injectable. Great for their health, but those are expensive. So with all that said, I don't believe any other broker can come in and just make these claims disappear. I do think we're doing a great job working with Gail, the team here, on managing your risk, but we never get to the end zone. Using football terms again, it's an ongoing process. And there is no silver bullet that's going to make these rising costs go away. We're doing everything we can to help you all manage that risk. We're very appreciative of the years we've served at the city, the council, the city of Jefferson, and hope to continue to do that.
If you have any sort of final points that you really wanted to get to today, please hit those. I'd like us to have a few minutes towards the end for
Sure.
discussion in any sort of direction that we need to provide.
I'd say that was probably somewhat of closing remarks. Would you
We've
say?
hit on every, I think.
And we are looking at, obviously, the reinsurance. One other point I would make, the fully insured market after ACA, there was dozens of carriers out there. Principal Financial Group's a good example. They were mostly retirement oriented, but they started to dabble in the medical world. State Farm had medical insurance at one point. When ACA happened and all the pre-existing conditions were taken off the underwriter's table, we're down to 4 insurance companies in the United States. It's called BUCA, Blue Cross, United, Cigna, and Aetna. We were just with United, now we're with Blue Cross. Cigna's not a player in Central Missouri. Aetna's network is not as strong as Anthem's. So we're with the best network with Anthem. We're getting a 60% discount. The fully insured market, there is, we'll go out and get quotes and so forth there, but that market is condensed. Unless you're in a state like California where you have the Kaiser program, which is an HMO, the reinsurance market is still very robust. We'll go to over 20 carriers on behalf of the city. And when you're a partial self-funded employer, if you're having a good year, you're going to get some great opportunities and looks at that reinsurance market. When you're an employer that's having a tougher claims year or some high claimants, obviously they're all looking at dollars in and dollars out. And that's a tough market to go through, but again, that's our job to do that. So we certainly have every market that any other broker would go to on the reinsurance side, which is our job on your behalf. So thank you for that.
Thank you both again very much for being here and providing so much great information for us. And whether people want to trade seats or not is sort of up to them.
Sure.
So Chief Schofield and Ms. Perry, in Chief Schofield's materials provided to council, there was an approach recommended would you like to say a couple words on that?
Yes.
And then we'll open it up to any sort of final comments.
And I think to kind of piggyback on the elevation analysis, you know, if I was to put this in fire service terms, you know, if we were fighting a big wildfire out west, you know, we'd be fighting the fire, we'd be in the middle of it, and it'd be running out of control, and we'd be trying to get perspective on it. And we would say, get up in the helicopter and take a minute and hold, hover, and evaluate. And I think that's kind of our recommendation to council is that, you know, some things we do here, decisions we make today, while we all are well-intentioned, we want to make sure that they are strategic in nature and that we have a full view of the fire and that we're not going to do something that's going to make it worse and that we need to have a good idea of the environmental conditions that we're facing. And so that's our recommendation as staff, and I think we're pretty well united at all staff levels to say that to the council that yes, there's some things, there's definitely more work to be done, and we know that is pending. We're going to keep working on it. That's our commitment to council throughout the fall and even into next year. There's a lot of work still to be done, but let's take a moment now to hold, hover, and evaluate until we get a little more information.
Any committee member questions regarding the recommended approach at this point? Mr. Chair. Oh, Mr. Mayor.
Could I make a comment?
Please.
I'd just like to commend staff. I know council took this issue very serious, and they took it very serious. They have jumped on this program. They have briefed me all along the way. I mean, I think we all went into it looking that there may be some excitement and options available that ended up not available. But they have turned over every rock they could to try to pull this thing together in a very short period of time. So I know it's at council now, and I think you need to do what you think is appropriate, and that's the way it ought to be. But they have done a lot of work over the last week, and I just appreciate them jumping on it, taking it very serious, and Wall Street being a resource to them to try to make sure that, as Chief indicated, that we make the best decision for the long term. So thank you.
I appreciate those comments, and I join you in those sentiments. I also join in great thanks to staff for the hard work here. Mr. Molman, if the committee, which is also made up of the entire council, wanted to communicate direction or accept the recommended approach, would we need to save that for perhaps a special meeting that starts in 8 minutes, or could this committee, as we are currently constituted, share that by vote?
Yeah, I think it would be appropriate for this.
Okay.
Since this is primarily tied into the budget conversation.
Thank you very much. Any final questions or comments or a motion?
I make a motion that we take upon the recommendation of staff to continue on at least through this budget year with the current direction.
So to adopt option 4? Great, thank you.
I'll second.
A motion in multiple seconds. Any comments, questions at this point on the motion? Seeing none, roll call please.
Pollers, Deacon.
Aye.
Hensley.
Aye.
Lester.
Aye.
Mealy.
Aye.
Schwartz.
Aye.
Spencer.
Aye.
Spicer. Wiseman.
Aye.
Wright.
Aye.
Motion passes.
Thank you very much, and thanks again for all the hard work and for everyone being here today for this discussion. Okay, we have about 6 minutes left, and obviously it's not time to move on to any of the department presentations, I don't think. But coming out of last meeting, Councilman Spencer was going to have an opportunity to spend a couple more minutes on a line of questioning that he was on. So I think that's what we'll do now, and if there's time for additional discussion afterwards, then we'll get to that.
Thank you. Mr. Oak, there were some statistics that you provided to us on the screen at our last meeting. And based on your job description, developing and administering general supervisory training for all directors and managers and supervisors, such as sexual harassment training or drug and alcohol abuse training, how many of those trainings did you accomplish last year?
I don't think we did any citywide trainings last year. We've been working on rolling out the online training program. So we've had a number of employees start that process.
Another core function of your position is to establish and maintain and administer a citywide performance appraisal system. How many of those appraisals did your department oversee or tabulate in the past year?
We don't oversee the performance evaluations themselves. The department directors oversee them within their departments.
But you tabulated, you receive them.
They come in to go into their personnel files and we track them.
It's not part of. My final concern is that, again, this was not part of your statistical data that you provided, was that you've been directed, since I've been on council and by previous councils, to conduct exit interviews. How many of those did you conduct in 2022?
I don't know offhand, I'd have to pull that information.
I can give you a couple examples of opportunities that were missed. We missed out on doing an exit interview on a fire captain that had served 33 years on the fire department and a 37-year employee within public works. So I think we're losing an opportunity to learn from our senior staff that are leaving the organization to capture important data as it relates to pay or benefits that are really a part of your department and responsibilities. So in closing, I guess I'd like to just say real quick, based on 2 to 3 previous salary studies that was provided, that your position has been and is currently being paid above market value. So I would really encourage my colleagues to strongly consider reclassifying the HR director position to an HR coordinator position, because I feel it's abundantly clear that we are not receiving the value of performance as it relates to the current salary being paid, and that this reclassification is truly more reflective and accurate of an HR director's abilities is capable. So, thank you.
Councilman Mealy?
You know, if I had questions like this, I would go to the individual's office and hash it out with them. I mean, this grandstanding, we're not a courtroom television show, guys. That's all I have to say.
Okay. Is there anyone here today to make a public comment? Just 1 second. Seeing none, Councilman Schwartz.
You know, Councilman Mealy, after you did the same thing to the committee that put together the program that we're going to use for looking at our structure and all that, I think that's kind of funny that you want to bring that up now. Just, that's all I want to end with.
Okay, thank you very much. Let's see, any final committee discussion regarding the budget? Any final comments from staff leadership?
So at the next meeting then, we would have Parks and Recreations on the calendar, as well as Ms. Senzi with the grant reorganization. We have had previous conversations about the time frame for them to be on the schedule. So if it is okay with this committee, we'll proceed with those 2 items and then finish up with the general fund, some of the other funds, and eventually get into fire and police as well. Those are the things we have left to.
So after Parks and Rec and Ms. Senzi, then you would present.
I was prepared today, but I will be prepared to present the rest of the general fund, sales tax, and some of our special revenue funds.
Which usually go
pretty quickly before we go into police and fire, and then those will be the last ones that we cover before the committee starts their discussions.
And I think for purposes of planning, I think this probably officially ended the HR department's presentation of their budget. Not that it won't come back up again in future meetings, but okay. Well, we will reconvene in a couple minutes as a completely different body. But I appreciate everyone being here today, and I'll call this meeting adjourned. Our next meeting is Monday night, the 28th, 5:30 p.m. to 7 p.m. And then August 31st, a week from today, from 12 noon to 1:30. Thank you all very much. First
They're going quick? They're going quick, yeah. My last one, 2 days. Tomahawk. Tomahawk.
That's the only thing on the agenda.
Yes, and that's really all we assumed this was going to be.
I agree. Yes. And my only remaining question, which I probably should have asked Brian, let him know, is get out of here, already taken care of. Hopefully Ron hasn't left until
Is the mayor still here?
What's the name of the street?
Hensley's expected
I know where it
to
is.
take his seat, because technically it's a council meeting.
Allers, Deacon, Hensley, Lester, Healy, Schwartz, Spencer, Spicer, Wiseman,
Here.
Wright.
Here.
We have a quorum.
Okay, that takes us to item 3, discussion regarding our regular scheduled meeting on September 5th, which is Tuesday following Labor Day. There was a discussion from Councilman Allers. I think Councilwoman Wiseman may have had some comments as well, but I mean, that's the issue before us if you want to make an adjustment to our schedule. Councilman Schwartz.
I'm just of the opinion we have too much stuff to do. I don't see any real reason why we need to move it.
Councilman Hensley.
So everyone's aware, because of the move from Monday to Tuesday, I will not be able to attend that evening either. But not that that should affect any of your judgment.
Okay.
Well, we're here.
I mean, it may be a good idea to just confirm attendance on the Tuesday night to make sure that the quorum would be present. It's rare, but we have had that happen where we there was a lack of communication and not enough people showed up. So it may be worth the discussion to just kind of go around and see if that Tuesday is going to present a problem for any, an unavoidable problem. Because I think
Councilman Allers
we're already
raised it,
hearing
I assume he can't. Councilman Mealy? You will be here?
Yeah.
You can be here if it, I will be here. I don't know about Councilman Spicer, you,
I'll be here.
and Councilwoman Wiseman?
At this moment, I will be able to be there. I have some emergent things that are happening and swirling around in my legal world. So that's the best I can do is say at this moment I can be there.
So potentially 3, up to 3.
What important items would be on that agenda? Are there any?
Your contract of the yard waste, right?
Yeah, it would be the final contract vote for yard waste.
But again, that contract that we currently have has not and will not expire by the next council meeting.
Expires October 1st. Items. And then do we have the light tech?
There is a LIHTC item.
It's pending.
Yeah, pending. We reached, or had some communication from an individual who wanted to propose another resolution for council to support a low-income housing tax credit proposal. And we reached out to them and they said they could wait until the 2nd September meeting if they needed to. The deadline is the Friday of that same council.
There's also a wastewater contract that we're trying to get started.
So is that a problem if that's pushed off or not?
Yeah, they'll miss a deadline
Oh, on the wastewater.
on the LIHTC.
No, the light tech would not miss.
No, I
The
just-
2nd September
wastewater-
meeting would be the Friday of that week.
So there's wastewater, we need to do it?
It would miss the optimum time to start the project if we push it 2 weeks.
Councilman Mealy?
So do you need a motion here?
A motion would only be needed if there's a change to the schedule.
Okay.
Yeah, only if you're gonna eliminate that meeting.
I think with the LIHTC deadline that it would make sense that we meet provide the necessary time for folks.
Let's clarify, the deadline would be the Friday after the 2nd September meeting. So if we did cancel the 1st September meeting, they would still meet the deadline.
So it just,
But it sounds like the wastewater is important to do at this point. That's what I'm hearing.
We certainly could adjust if it was the council's choice to not hold the meeting.
And you would also have the option to suspend the rules at that second meeting, should you want to on that particular.
So it's up for,
It's already.
it's already been.
It's already up.
Vote on it now.
Oh. Yeah. No, probably not. It's
Not on the agenda.
Attorney
It's a
just went
creek bank
blank.
stabilization. Oh,
You haven't introduced
Let's
them.
amend the agenda.
it's a creek bank stabilization.
I don't have full information on the matter. Basically, the contractor was hoping to get notice to proceed in early September.
It's not pending.
So it's not a pending.
No, the 3 pending ones, I'm looking at the agenda from last week, are 2023-041, which is the addition of the parking spots on Duncan, and 2023-042, which is the landscaping contract, creek bank stabilization.
Yeah, that's the one we're
That's
talking
the
about.
wastewater.
That's the
Creek bank.
creek bank. That's the wastewater contract.
And then the Cordy contract for yard waste disposal. 3 that are pending right now. Then we would add, we know for sure that there's a LIHTC one coming as a resolution one time.
Mr. Mayor.
Councilman Spencer?
Can I ask a quick question on the LIHTC project real quick? I know it's not on the agenda, but I just want to preemptively be prepared. Have we encouraged those folks that are applying for that? Have they engaged the school district? Do they engage any of the surrounding neighborhood that would be impacted? I just want to make sure that, because that's what we've done.
Yeah, we'll pass that along, and we've had some, it's really been a very brief email conversation. We don't have any materials even yet, so it's just a communication on how they go about the process of getting on the agenda. So
if you could encourage that.
We'll pass that along.
My understanding though is that's a senior development, so it will not impact the schools. I don't think.
That's correct. That was in their email, so I apologize for not sharing that information, but that's about the only information we did.
Okay, thank you.
Anybody care to make a motion?
Motion to adjourn.
Well, that one too. Second on that.
I'll second.
All right, all in favor, say aye.
Aye.
We are adjourned. Thank you. Yes. Correct.